triple header. It's the evolution from Doctor Knows Best to informed consent, and alternatively, altruism versus atrocity, and finally, ancient Greece to Abu Ghraib and beyond. It starts out with ancient medical history and goes through recent medical history, then to ongoing current events, and even some predictions. So there's basically a pretty broad sweep about disease and doctors and medicine and politics. So if you do stick it out to the end, you'll decide whether all three titles are necessary and appropriate. We'll finish with an update of the more recent issues to get to our conclusion, basically of how things stand today, what has and what hasn't improved in healthcare, and the relationship with doctors and patients. And for those who wish after, we can take a few minutes for question and discussion. Throughout doctoring history, just like every other human pursuit, there have been wonderful physicians and terrible physicians. And I'm sure you know doctors don't have an exclusive monopoly on bad behavior. But because I've chosen to focus on the evolving relationship between doctors and patients, I'm going to talk mostly about physicians' bad behavior and what society and doctors themselves have done to correct it. So I apologize to any doctors here in advance, because in order to trace the evolution of current laws and medical success, we've got to muddle through many years of nasty human behavior in which doctors often participate. And my point was nicely phrased by the bard of Stratford-on-Avon: the evil that men do lives after them. The good is oft interred with their bones. I want to illustrate why and how the doctor-patient connection, usually presumed to be well-intentioned, evolved from a father-knows-best attitude that we call paternalistic to a fiduciary relationship. And as many of you know, a fiduciary relationship is one between two people, one of whom has superior knowledge about a particular item, but they're both interested in that item. The one with the better knowledge has used as a result to use in behalf of the one with the lesser knowledge. Now, a wise observer once said, laws aren't made until they're broken. And what do you mean by that? Well, generally speaking, things go along nicely in a homogeneous community because everybody knows what's right. But when there's an unaccepted violation of community morality, a law has to be made so that everybody's going to follow community standards. That is, if it's going to be a peaceable community. In fact, law is what we call it when our ethics become crystallized. Law is crystallized ethics. Of course, not all laws are ethical. We're familiar with unethical laws, such as those that impose segregation. More about that later. After we review some lesser-known recent history together, I believe you'll agree that there are good reasons why the law has had to step in to protect patients. Many people don't realize just how new the idea is of asking patients to agree to their treatment or getting their permission to do research with them. The essence of this talk outlines the path taken through history to be sure that patients know and consent to the risks and the benefits of medical treatment before becoming patients, and the risks and benefits of research before they become subjects of research. And the law has taken a critical role in this assurance. With reliably useful medical care, the courts began to push the idea of patient self-determination. Before then, doctors might speak to patients when it was absolutely necessary, but listening to them was a very novel idea. And today, if there were no patient consent, a doctor's intervention would be considered battery. And if there were no clear explanation of treatment, negligence would be the charge. Aided immeasurably by the discovery of antibiotics, medical treatment actually became more consistently effective about the middle of the last century. Until then, a visit to the doctor had about a 50-50 chance of doing the patient some good, and about an equal chance of doing harm. Only in the middle third of the century just passed did the long history of recurrent deviations from humane medical treatment finally prompt the passage of laws and regulations for research on and treatment of patients. And about the same time, idea of informed consent from patients for treatment was promoted. So let's start by looking at some history of the beginnings of the doctor-patient relationships, and you'll see why there wasn't even a wisp of an idea of informed consent. Hammurabi's Code, about 1700 BC, covered a lot of things besides doctoring. But surgeons of that era had to be very confident or very courageous. The reward for removing a tumor over the eye and saving the eye was a respectable 10 shekels. And should the doctor inadvertently cut out the eye, the consequence was amputation of both of the doctor's hands. Now, that was a very effective way of being sure that professional standards were maintained. The threat of amputation, I'm sure, was much more effective than what we use now, malpractice insurance. That persuades an inept physician to deviate, perhaps choose another line of work. Doctoring in Western cultures began as an art in Greece and developed as a paternalistic cottage craft over the centuries, with more than a little bit of magic and careful guarding of personal nostrums and the secrets, special secrets of practitioners. The obstetric forceps, for example, remained a well-guarded family secret of the Chamberlain family throughout 2 centuries, the 16th and 17th centuries, despite its life-saving role for arrested labor. And of course, cesarean section, which incidentally, of course, had nothing to do with Judas, it was a rare and usually lethal intervention. Historically, the best-known mentor of practitioners is Hippocrates. An open and truthful discussion with the patient was contrary to the mystique of medicine at that time. He gave all of his acolytes instructions to conceal most things from the patient and reveal nothing of the patient's present or future condition. And of course, he said that in Greek. Cicero, or as my high school Latin teacher would say, Cicero, that's what she used to say that to us. And Cicero in Rome counseled his fellow followers never to warn anybody of impending danger, especially if there's nothing that could be done to avoid it. There was a medieval surgeon in France by the name of Henri de Monville, and he took a leaf from Cicero's book, and he advised his colleagues to promise a cure to every patient, but tell only the friends or the parents if there was really any serious danger. And he recommended, paradoxically, either exaggerating the problem or minimizing it, whichever hyperbole was necessary to get the patient to cooperate. In the newly independent United States, Dr. Benjamin Rush advised the physicians that they ought to inform the patients just enough to assure compliance with doctor's orders, but under no circumstances were they to relinquish absolute authority. Thomas Percival published the first modern work on medical ethics in England just a year before he died in 1804. And he urged physicians always to lie to a patient with a terminal illness, or any other time he thought that truth would be harmful. And of course, in his day, nothing much could be done about terminal illnesses, so he considered lying regrettably to be forced upon him by his professional role that really demanded deception. The AMA endorsed veracity, but only when you're dealing with another doctor. No mention was ever made for need for telling the truth to patients. And it shouldn't come as a surprise today that many cultures continue to promote that view. possibly less in the United States than abroad, but all the influx of new cultures has influenced that argument. Some immigrant cultures absolutely forbid the doctor to discuss bad news with a patient. And they insist the family has to be told, and they will decide what to disclose to the patient. Usually they address a family elder, and he is the one who talks to the patient, tells them what he believes they need to know. There was an unfortunate social condition in America, slavery, which gravely distorted the idea of consent for medical treatment. Most citizens, both North and South, looked upon black slaves as property, not as persons. And before there were any ethical codes in the late 1800s, physicians supported experimentation with slaves, and they assuaged their conscience by the ignorant or else self-deceiving advice, perhaps, of excluding slaves from the human race. In America, before the Civil War, the law dictated only a master could consent for medical treatment for a slave. The slave didn't have to agree. And of course, only a healthy slave was an asset. An injured one was clearly a liability. And the slave owner often withheld permission from the doctor when a cure couldn't be assured because it was considered throwing good money after bad. There are many legal archives, but one of them records a case concerning a slave who sought a doctor's care, but he had a bad outcome from the treatment. The slave owner sued and collected damages from the doctor. And why was that? Because the owner hadn't given permission for treatment and his property had been damaged. In the field of medical research, there are journal articles in the late 1800s reporting experiments without consent that were done in the United States that would anticipate the Nazi doctors' atrocious human experimentation by almost a century. In Georgia, a slave was placed in a pit oven to study the causes and treatments for heat stroke. In Virginia, boiling water was placed in a pit oven to study the causes and cures for experimentation seeking a cure. Ephraim McDowell is celebrated as the father of gynecology. He got that title because he was the first surgeon to successfully remove a large ovarian cyst from a white patient. No one seems to write about the previous 4 attempts on slaves, which were fatal. Crawford Long from Georgia, among others, is credited with an early discovery that serendipitously introduced anesthesia to America. After an ether party, where getting stoned was very popular in those days, he noted a bruise on his leg, but he didn't remember pain associated with the bruise. And he demonstrated ether's non-recreational effectiveness by amputating 2 fingers from a slave. He used ether to cause unconsciousness, and he amputated painlessly. But on the same slave, who was now awake, he amputated without anesthesia, leaving no doubt that there was pain when you didn't use ether. Neither amputation had any medical indication. The need for consent was approached earlier. In 1880, a patient with cataracts sought surgical relief. And he was a prudent guy, so he requested his physician to operate one eye at a time. Well, the surgery was going so nicely that the surgeon decided to operate on both eyes. And he removed cataracts from both eyes. Unfortunately, the patient became blind in both eyes. And he sued the doctor for malpractice. At trial, the surgeon provided witnesses who testified the surgery had been done properly and there had been no negligence that caused the bad outcome. Hence, there was no malpractice. The issue of consent by the patient wasn't raised because what the doctor had done was considered to be within his judgment. The patient had consented to eye surgery. Once professional help was sought, the type of eye surgery was up to the doctor. Now, had the patient sued for battery, meaning touching without consent, the case might have gone differently. In another lawsuit in England in 1850, a Dr. William Case persuaded a 14-year-old girl to have sexual relations with him by convincing her it was a form of medical therapy. And the crime for which he was successfully prosecuted, interestingly, wasn't rape, but battery, touching without consent. In the same era, if a patient refused a medical procedure, it was considered evidence the patient was incompetent, not mentally capable of making decisions. In one case, a patient accused a surgeon of forcibly chloroforming her and removing 6 teeth. The doctor's defense was that the surgery was necessary, and it was performed competently. And besides, he explained, the patient lacked the expert knowledge to judge whether or not she should have had her teeth removed. And there was, on that case, a hung jury. The doctor went free. And for the most part, the courts left it to the doctor to decide what was the best interest of the patient. It would have been considered a radical idea in that era to consider that the patient might be best at deciding his or her own best interest. 2 cases in Minnesota and Illinois in 1905 and 1906 heralded a change in perspective. It was ruled that consent was invalid because information had been denied to the patient. One case concerned surgery on a patient's ear. The operation had been done on the ear opposite from the one for which the patient had consented. The doctor denied he'd operated on the wrong ear. He said once the patient was anesthetized, he examined both ears and decided the other one needed surgery more. And there was a second case. This was a case in which the patient refused a hysterectomy. The patient's husband had assented in order to avoid the need for force. Force, indeed, was often the practice if a doctor had recommended an operation. The doctor and her husband deceived the patient in order to perform a hysterectomy. And the doctor also testified that it was the disease itself that made the patient incompetent to give consent. And of course, what was the disease for which hysterectomy was the cure?
Oh, God.
Epilepsy.
Epilepsy.
Totally unrelated neurological affliction. Well, both of these cases were a turning tide. They both found for the plaintiffs. And the decision spoke of a fundamental right of a patient to refuse incursion on bodily integrity. Well, these 2 decisions foreshadowed a 1914 landmark decision by Justice Cardozo, later to be in the Supreme Court. And he cited these cases. He wrote, quote, "Every human being of adult years and sound mind has a right to determine what should be done with his own body. And a surgeon who performs an operation without his patient's consent commits an assault." And this, of course, was a definite change in legal influence on medical practice. It presented the idea that even a necessary and competently performed operation is unacceptable if it hadn't been done with the patient's knowledge and the patient's permission. Now, that really shouldn't come as a surprise. A patient would be justifiably puzzled and inclined to be a little doubtful if a paternalistic doctor of a bygone era were to say, "Now, don't you worry, I'm going to take very good care of you, but for the next 6 weeks, I'm going to give you several bottles of fluid through a needle in your arm, and you'll be nauseating and vomiting a little bit, and you'll maybe be a little weak, but in a few weeks, you'll go to the outpatient department. You'll lie under an X-ray machine that may be a little noisy. Maybe your skin will discolor a bit. By the way, your hair will probably fall out, but it'll probably grow back. On the other hand, there's really nothing to worry about." That doesn't sound like everything is just fine. And nobody here would be likely to blandly agree to that sort of a thing. Maybe we'd have a few questions. Trust me, these days doesn't cut it as much as it did in those days. Indeed, everybody's entitled to know much more about what the problem might be and what any intervention might offer in the way of risk. There was a case in 1957 that furthered the concept that for consent to be valid, the patient had to be informed. Mr. Salgo became paralyzed after a special fluid for X-ray visualization was injected into his bloodstream in order to see the major artery in his heart. And he asserted that he had not been told that paralysis was a risk of the procedure. And the court found the physicians had a duty to disclose the facts that were essential for a patient to understand enough of the risks to make a decision to undergo a procedure. Then, in 1960, a Kansas court found that Dr. Klein had been negligent because he didn't tell Mrs. Nathanson of the hazards of cobalt radiation for breast cancer. In court, she exposed her chest. And because her ribs had been destroyed by the radiation, each beat of her heart could be seen pulsating and distending the overlying scarred skin. Justice Schroeder affirmed the new legal direction by stating, quote, Anglo-American law starts with the premise of thoroughgoing self-determination, and it follows that each man is master of his own body, and he may, if he be of sound mind, expressly prohibit the performance of life-saving surgery or other medical treatment. Well, nowadays, a judge would have used the phrase, each man or woman is master of his own body, but that was then, and this is now. Much earlier in our history, there was a time when doctors totally brushed aside the humanity and well-being of patients to promote a political and social ideology with worse trespasses on patient self-determination. The American eugenics movement demonstrates this energy when an ounce of science is mixed with a ton of zealotry. One such program resulted in the laws promoting the sterilization of over 60,000 Americans starting in 1907 and lasting really right up to 1972, which is in my recent memory, when the lives unworthy to be lived was propounded in a book by a jurist, Professor Bindung, and a psychiatrist, Professor Hocha. In America, it never went beyond sterilization. That was bad enough. However, in Germany, a program of racial cleansing under a ruthless Nazi regime led from compulsory sterilization, ultimately to murder, euphemistically termed euthanasia. Later, when the mass murders in Germany were rampant in 1943, Dr. Fisher wrote, quote, "It's a rare and special good fortune for a theoretical science to flourish at a time when the prevailing ideology welcomes it and its findings can immediately serve the policy of the state." And interestingly enough, Fisher continued his influential role in the medical establishment of Germany for many years after the war. And this atrocious behavior led to rules in the United States for consent in research. After World War II, it became apparent the medical profession in Germany had been co-opted by the ruling political power. The professional group that had the largest percentage of Nazi Party members was medicine. It was not a minority of professional outcasts that sorted civilian prisoners for either work or execution. Nor did their fellows ostracize the doctors that carried out atrocious experiments. In fact, it was the doctors that upheld the ethics of medicine who were ostracized, and protesters sometimes shared the fate of the persons whom they were trying to protect. It's easy to see how the Nazis based much of their master race ideology on American foundations. Sterilization law was passed in Germany in 1933, 26 years after Indiana, following careful study of California's laws. In 1936, Lachlan and other Americans who had written for German journals received honorary degrees from the University of Heidelberg. Eugenics programs in Germany began after Hitler became chancellor with a compulsory sterilization law for congenital mental defects, schizophrenia, manic depressive psychosis, hereditary epilepsy, and severe alcoholism. In 1937, after German doctors Abel, Schade, and Fischer provided expert reports, physicians sterilized 300 children because they were colored. In 1939, 9 psychiatrists and 39 other physicians screened 250,000 mental patients for seriousness of their illness and curability and genetic factors, and 75,000 of them were marked for death. In 1940, carbon monoxide was the agent of choice. 70,000 German citizens that were mental patients in German hospitals were reported in meticulously kept records to have been killed. In 1941, with the invasion of Russia, unique units of soldiers and police, Einsatzgruppen, moved with the armies into conquered territories with the specific mission of murdering gypsies, Jews, and mental patients. The chief of the regional SS soon reported he had supervised shooting 4,400 Polish mental patients, 2,000 German nationals from a Prussian institution, demonstrating that they went about impartially murdering defectives regardless of their nationality. Himmler, in December of 1941, asked the doctors that had carried out euthanasia to comb the concentration camps for those who were unable to work or otherwise undesirable, resulting in a vast number of deaths by the poison gas Zyklon B. In the same year, Professor Fischer speaks of Jews as beings of another species. In this sort of pronouncement by somebody regarded as a medical authority, dehumanizes victims, not unlike how the slaves were characterized in America, and gives predisposed people permission to act on their most sordid impulses. Dr. Meneke, in January of 1942, wrote a large contingent of doctors and male and female nurses. They moved to Poland to set up extermination camps. In December of that year, Dr. Halliburton reported that over the summer, he had been able to dissect the brains of 500 feeble-minded patients. And Dr. Schneider opened an institution for the study of idiots and epileptics, after which they were killed and their brains studied. Dr. Halliburton continued his work and reported in 1944 he had collected 697 brains, including those that he had dissected himself. And of course, Dr. Menge's own records show that in 1944 he sent sera from twins he had infected with typhoid, eyes from gypsies, internal organs from children, to be studied at the Anthropology Institution. After the war, Dr. Halliburton admitted he had provided extermination camps with containers and preservatives. He reported to his interrogators at the time that he approached the camp saying, "Look here now, boys, if you're going to kill all these people, at least take the brains out so we can use it." And again, after the war in 1949, he remained the department head of the Max Planck Institute. Halliburton's brain collection was shared for study at the University of Frankfurt until 1990, when the brains were buried in a cemetery in Munich. No nation compared in scale with the meticulously organized and highly prioritized deliberate medical atrocities in Germany between 1933 and 1945. In all, there are official medical records of 350,000 sterilizations, and these stopped in 1939 because the judges and the doctors were busy with the war, and because murder had been substituted for sterilization. In addition to the hundreds of thousands of mental patients murdered quickly, there are an estimated 80,000 mental patients in German and French mental institutions that died of starvation after the euthanasia program came to a halt. Millions among the gypsies and Slavic slave laborers and homosexuals, Jews and Russian, Polish soldier prisoners were killed with the help of expert doctors who selected those fit to work and those fit only for experimentation or death. Their own careful documentation led to the execution of several German physicians after the Nuremberg trials for crimes against humanity. And they cited these cases. German doctors immersed prisoners in ice water to learn how best to resuscitate their hypothermic German pilots that had been shot down in the North Sea. And they kept meticulous notes to see how long it took to freeze a prisoner to death and to learn the limits after which resuscitation of their pilots would no longer be possible. Prisoners' limbs were fractured and contaminated with dirt to see if the newly discovered sulfur drugs found in Germany would ward off infection. And those who think that these things are so impossible, I had in the 1960s a woman Polish patient in Denver who had immigrated from Germany. And she had her tattooed number on her forearm. And we got to talk about her past history, obviously. And she showed me the very poorly healed fracture, she limped into my office, of her leg. And she had been one of those persons whose leg had been deliberately fractured, rubbed in the dirt in order to see if the sulfur drugs would cure the infection. The sulfur drugs obviously worked. Further sterilization of inferior races by radiation was tested on prisoners, and that led to sloughing of the skin and genitalia as doctors tried to determine optimal X-ray. Prisoners had gasoline injected intravenously. In order to determine the limits of human endurance for pilots for oxygen deprivation in simulated high altitude, prisoners were placed into airtight chambers and air withdrawn until they suffocated. And this very year, 2013, the Space Medicine Association withdrew an award called the Huber-Strughold Award after Strughold was retrospectively linked to similar vacuum chamber experiments noted above. He was one of the several German scientists who immigrated to America that never were indicted. After the war, when these records became unveiled, there was enormous controversy among medical scientists as to whether these could be of actual benefit for future patient treatment. And there were three kinds of arguments. First, there were questions regarding the rigor of the methodology. Many researchers dispute the accuracy of the results. And their issue was only whether the conclusions were dubious and provided useful knowledge. There were critics both in science and the disciplines such as the humanities who declared the experiments were so atrocious that it didn't matter. Civilized people would not use that information. The third group opined that it would be a tribute to those sacrificed to use the information if it were valid for the benefit of future patients. Well, in the interest of medical ethics, a lot of observers have tried to understand the doctors in Germany, the Nazi doctors' mentality. Robert Lifton, who's a psychiatrist, wrote a book called The Nazi Doctors in 1986. And he conceived the idea of doubling. And this he described as a psychological state that was necessary to avoid mental disintegration under extreme circumstances. Doubling allowed a person to maintain the normal intimacy of human relationships with wives and children and friends in the real world, while simultaneously allowing themselves to carry on otherwise unthinkable behavior by the same self in a parallel world. Several of the involved Nazi doctors later committed suicide, and we can only speculate whether it was because of remorse and guilt or because of the shameful consequences of exposure, or simply the collapse of their ideology, the end of an unrestrained era for them, and no professional future in sight. Christian Pross, in the book Cleansing the Fatherland, comments on the diary of a Dr. Voss and the pleasure he derived from the special bonuses of war, a professorship at Posen, and command of the crematorium there. He quotes Voss's diary, quote, "How nice it would be if we could drive a whole pack of Poles through the ovens. Yesterday, 2 wagon loads of Polish ashes were taken away. Outside my office, The robinias are blooming beautifully, just as they did in Leipzig. The commandant of Auschwitz, Rudolf Höss, in his autobiography described the mass murders and the suffering it caused him. But he neglected to mention the 3 carloads of valuables he removed from Auschwitz. Regarding the eugenic practices, the prominent German doctor explained the program with a medical paradigm. The doctors were, he opined, simply eliminating groups that were like a cancer in the German body that clearly had to be cut out, as it were. None of them remarked on the personal and economic advantages that they had gained. Dismissal of Jewish scientists from the Kaiser Wilhelm Consortium provided dozens of jobs for professional promotion and opportunities for advancement, and grabbing the reins and funds of research grants. Pitifully few of the many hundreds of associated scientists and doctors had any objection. On the contrary, part of the documented post-war archives include an official joint letter to Hitler pledging themselves specifically to the goals of the Nazi hierarchy. And we prefer to think of this behavior as so egregious and so deviant that it merits a novel explanation. Author Pross, on the other hand, offered an explanation that supports the idea of Hannah Arendt, the American author, who created the idea of the banality of evil. Pross conjectured that the Germans were simply being practical. And he wrote, quote, "Along with the homeless, the beggars, the inmates of insane asylums, the Jews of the Eastern European ghettos, the German authorities eliminated the visible poor, those people who required unnecessary expenditure during their lifetime. Their mistreatment and liquidation provided housing, employment, assets, old age pensions. The killing of the useless provided beds for physically wounded soldiers and civilians during all-out war by emptying mental hospitals, foster homes, and institutions for the handicapped. Suddenly there was permission to take over the positions of a disenfranchised segment of the society. The opportunity to work out the frustrations and disappointments of daily life was provided now by government authority. Practical benefits accrued to the German states from massive confiscation of wealth, property, profitable economics of slave labor without the necessity of supporting the slaves who were expendable and in seemingly endless supply. All of these commentators remind us how poorly we learn the lessons of history, failing to be aware of the baser instincts of human beings while we all aspire to the nobler. Outward manifestations of piety and righteousness do not protect the citizenry. Every belt buckle that the German soldiers wore, every belt buckle had embossed on it, Gott mit uns. God is with us. Over the door of the courthouse in the Palace of Justice in Nuremberg were engraved the 10 Commandments. The people that established those commandments in the Old Testament was precisely the people deprived of citizenship and human rights and life under the laws promulgated in the name of the very city, the anti-Jewish Nuremberg laws of 35. So what was the reaction to this unconscionable abrogation of medical ethics, in which doctors became embroiled in crimes against humanity? Well, from the war crime trials comes a series of regulations. And they regarded research, and it was called the Nuremberg Code, and is called the Nuremberg Code. And the first statement is, the voluntary consent of a human subject is absolutely essential. The Helsinki Declaration of 1962 has several revisions, but it remains as its essential statement. In research on man, the interests of science and society should never take precedence over consideration related to the well-being of the subject. Well, that's pretty heavy. And you'd think you'd be interested if I could report that the world of medicine and medical research cleaned up its act. But I can't. Despite the notoriety of the behavior and the codes and the declarations that resulted right here In the United States, American doctors continued studies that had begun in the 1940s and went on for 3 more decades. American citizens in civilian hospitals were subjected, without their consent, to radiation in the interest of learning how to defend the country against atomic war. And after these experiments became declassified, President Clinton set up the Advisory Commission on Radiation Experiments in 1993 to investigate and suggest compensation for the surviving subjects. Subsequently, after more decades had passed, additional studies in which American soldiers were exposed to atomic blasts were revealed. And more recently, blood disclosures such as leukemia began to be reported retrospectively in children exposed to fallout from the errant winds from the bomb tests. More than 20 years after Nuremberg, Dr. Henry Beecher in 1966 New England Journal cited 22 unethical experiments in America, including universities and the Veterans Administration and military and private hospitals. Examples included failure to treat cohorts of soldiers that had strep throat with penicillin that was known to prevent rheumatic fever. Some soldiers received placebo and some got sulfa, but the results were more than 70 unnecessary cases in soldiers of rheumatic heart disease. And the interesting thing, no consents for experimental treatment had ever been discussed, much less signed. Another poorly researched experiment was the injection of malignant melanoma cells from an afflicted girl into her mother to see if immune substances could be generated for treatment. The patient died the next day, demonstrating the dubious, ill-conceived foundation for such an experiment. The unwarranted risk for the mother, although she signed a form, eventuated in her death 15 months later of malignant melanoma. And I always have to ask, was a consent form from a desperate mother a valid, informed consent? The most notorious American experiment that begun before the war was not a part of Dr. Beecher's article. It concerned the failure to treat over 400 black men for syphilis, quote, to observe the natural course of the disease. As if centuries of observing the outcomes of syphilis had not clearly demonstrated the outcomes. The Tuskegee study began in 1933. Despite the availability of penicillin since 1946, the subjects continued untreated until 1972. And no one protested the study despite several papers that appeared in medical journals. And saddest of all, it was done under the auspices of the United States Public Health Service. Not until the second Clinton administration were an apology and reparations offered, too late for many who died or suffered the physical and mental ravages of that disease. Yet another inexcusable study, which wasn't revealed until 2010, although it was done in 46 and 48, intentional exposure of 1,300 Guatemalans by American researchers to syphilis, gonorrhea, and chancroid. A prominent and respected Surgeon General, Dr. Parent, who made a lot of outstanding pioneering contributions to public health in the U.S., nevertheless was complicit in this. He had commented that the research could never have been done in the United States. Another apology was made, this time by Hillary Clinton, who was Secretary of State at the time. And this year, 2013, according to a JAMA surgery study, researchers examined hospital discharge records of 350,000 patients with failure of critical blood circulation in the legs. Treatment options were either amputation or surgical revascularization, that is, trying to restore blood flow to the legs in an attempt to salvage legs. The racial differences were still significant even after adjustment for variables like income, insurance, and availability of health care. Black patients are more likely to undergo amputation, 56%, compared with Hispanic, 48%, and white, 35%. Not clear if this is due to physician or institutional or patient factors, but the statistics stand. Subsequently, doctors in many different countries have disgraced the medical ethic by using their medical knowledge to further political or personal ambition, acting against the life and health of someone under their supervision. Such was the case in the Soviet Union, where psychiatrists treated political dissidents as mentally ill candidates for institutionalization. Such was the case in Chile, where doctors revived tortured prisoners so political police interrogations could continue. Such was the case in the 1950s here in the United States, when LSD experiments caused the death of American soldiers experimented upon without their knowledge. After a lapse of more than 30 years, it was revealed that soldiers in Hawaii, Alaska, and Maryland were unwittingly involved in exercises using chemical agents, including nerve gases such as sarin, during the Cold War era of the 70s. As recently as 2009, former soldiers have sued the government for ill effects suffered when subject to these experiments without their knowledge. Such was the case when British physicians in the early years of national health programs advised all their older patients nothing more could be done for kidney failure. Despite the availability of dialysis, they disguised a political economic rationing decision as a medical fact. Such was the case when Japanese doctors used Chinese civilians to test germ warfare agents before and during World War II. Unlike the German soldiers, they weren't prosecuted. Why? Because the United States wanted the data for its own germ warfare program, and the trial would have revealed information that the United States wanted to keep secret. Such was the more recent American disgrace in Abu Ghraib and other lesser-known detention areas when physicians, at the very least, covered for illicit actions that had resulted in the deaths of prisoners under abusive interrogation. Such was the case in a film released in 2011 entitled Nuclear Savage, The Islands of Secret Project, using footage from United States government film recently declassified, combined with interviews with survivors. This nightmarish tale is told of the 67 hydrogen bombs we dropped on the Marshall Islands in the 1950s. Anybody ever hear of that? 67 bombs dropped on the Marshall Islands?
No.
Incredible. I hadn't heard of it until I read this. And this was the equivalent to more than 7,000 Hiroshima bombs. The largest U.S. hydrogen bomb explosion was on March 1st, 1954, when residents of the two tiny atolls there were told their islands was safe. They suffered direct exposure to nuclear fallout and serious, often deadly health consequences, including thyroid cancer, genetic defects, skin malignancy, miscarriage. Subsequently, United States doctors were brought to the island on 72 research trips, not to treat the people, but to study them closely so the U.S. government could learn about the effects of nuclear fallout. As the years went by, more and more people became ill, but never received serious treatment. Over several decades, they were told there was no connection to the U.S. hydrogen bomb explosions. And later, some came to the United States and received treatment, as usual, too little and too late. The torturers and conspirators, as pointed out by the authors of Medicine Betrayed, were most often those in a structure with its own culture and mission, such as the military or the police force. And they were the ones then and now who stated something you probably heard before. They were simply following orders. But what about current research issues, although some of these are fairly current, and protection of subjects? There was a key document, the Belmont Report, by a commission created by Congress, made public in 1978, stressing the principle of respect for persons and the duties of beneficence and justice to guide medical ethics. The principle of respect for persons notes that persons have a right to decide for themselves whether to participate in research, informed consent, And those people who are unable to understand or in circumstances that make them readily coerced have to be protected. The duty of beneficence has, as a general rule, maximized the benefits and minimized the harms. And that of justice, of course, means people should be treated fairly. For example, when public funds are used to create useful treatment, justice demands that persons from the experimental research groups be included among those that benefit from the research. And consent, of course, doesn't relieve the researcher of responsibility for protecting the patient's life and health. Research may not imply a therapeutic benefit in order to attract subjects when no such possibility exists. If you check some of the recruiting ads you see in newspapers almost every day, they imply therapeutic benefits for subjects of tests for new drugs when the first phase is tested only for toxicity. They're testing to see whether that's going to kill anybody with the testing drug, not for efficacy. Now, there may be people who will do that, but they're certainly misleading them when they imply that this is going to be some sort of curative. Researchers and drug companies offer financial incentives to volunteers. I'm not sure volunteer is the right word, but in our society, the group that offers themselves for subjects, as in research usually, because they need the money, is too often not the group that ultimately benefits by the information. Research and therapy often overlap. It's ethically imperative to inform patients whenever experimental treatment is anticipated. Even the intent to improve the patient's health doesn't relieve the physician of the responsibility to regard the treatment as research, and it demands institutional review board oversight. There continue to be violations. Not long ago, over 15 American universities' research programs were closed down. They had to change procedures significantly to ensure compliance. In a bygone era, there was an assumption that if a patient refused a medical intervention, then he or she has to be incompetent. And that idea had been abandoned. Some patients have goals in which life and health are not their highest value. This was the case with Mrs. Condura, 77-year-old widow who in 1978 refused her third partial amputation for gangrene of her feet due to advanced diabetes. Her daughter and her doctor went to court to obtain legal guardianship so they might compel her to have the surgery. The judge at the appellate level noted she had recently consented to the first two operations. If she had been incompetent to consent then, he asked, why was she now incompetent to refuse? Their reply that she had previously made the right decision wasn't acceptable. The judge pointed out the court wasn't judging the patient's values or the medical appropriateness of the decision, but the patient's capacity to make a choice. And it's clear that the patient knew her medical condition, the risks and benefits of the procedure, the possible risk including death if she refused it. And under these conditions, he said, competent patients have to be able to make regrettable or even tragic decisions. And this, of course, was the ultimate triumph of patient self-determination over the doctor knows best doctrine. In other words, the court was upholding the principle of respect for patient autonomy, self-determination, over the principle of physician beneficence, that is, what the doctor thinks is best for the patient. Well, in these last 5 minutes, I'd like to give some summaries of this. Once again, I don't intend to cast a poor light on medicine and doctors, or ignore the many from the past who've contributed greatly to human health and welfare. We ought not diminish the contribution of doctors of previous centuries. To name only a few, there were Edward Jenner, who gave us smallpox vaccination in 1796 and seems to have eliminated the disease in the United States. Louis Pasteur, who gave us the germ theory in the 1860s through the 80s. Joseph Lister taught antisepsis in 1867. Banting, who initiated insulin for diabetes 1922, Daston Raymond diphtheria and tetanus vaccines. 1926, Alexander Fleming, who found penicillin. 28, although he didn't develop it at the time. There are lots of others. My point is this. Measured by the whole picture of human illness, their findings didn't increase the only 50-50 chance of the entire population that might be improved by a visit to the doctor before 1950. Let me reiterate that in order to explain the evolution of current medical practice, informed consent became a necessary element to protect patients against harm, to promote their individual interests and values as they see them, and to promote self-determination, which is a basic element of our culture. Gradually, as society changed, so did the doctor-patient relationship. Over the past half-century, the law moved to endorsing self-determination and necessarily involving patients in making decisions. They had to be given sufficient information. They had to be able to do that to participate in their own care. It was necessary, of course, that they had the mental capacity and that they could know what their options were. That had to be carefully explained. Informed consent and a consent form are very different things. Informed consent, of course, is a process, not only a document, and it involves discussion with the patient in order to determine the goals of the patient. Problems can arise when the patient's objectives are incompatible with the doctor's view of the circumstances, or when values are in conflict, but you can never settle a conflict if neither the doctor nor the patient is aware that there is a conflict. And that's why communication and clarification is essential to the therapeutic relationship, something that is, as we started our discussion today, doctors and patients never spoke to each other, they just listened. Before we review the doctor-patient relationship that most of us experiment, let's consider the military doctor, whose activities have been scrutinized recently because of more than a decade of well-publicized wars. Certainly doctors aren't practicing in the poisonous atmosphere of Hitler's Germany or any other totalitarian government. Yet doctors, of course, serve in the armed forces, where hierarchy and group cohesion is critical. Group mission strongly fostered. Individual dissent, or even compliance, if it's reluctant, appears to be punished to some degree. And there have been articles in American journals both debating and deploring the role of military psychiatrists and other doctors in prisoner interrogations. Atrocities reported during the recent wars were to some degree traced up the chain of command to those who provided authorization for the use of torture. Actually, it's even to the point when the then commander-in-chief now fears to travel outside the United States because he is subject to criminal liability in many countries abroad. Apart from physician research and political involvement, what doctors have to consider in everyday ordinary medical practice? Well, looking at the need for universal health care, it's clear that society has to place limits on what we can offer. We're hearing more about the necessity to ration care. Doctors have to be prudent users of resources. What's covered in an insurance plan is not the individual bedside doctor's decision. It's my opinion the doctor has to focus impartially on the needs of the individual patient. Patients should never have to wonder in whose interest the doctor is working. And if the doctor uses professional skills against the patient's interest or deviates from a position of individual patient advocacy in therapy or in research, he or she then starts down a slippery slope. The law can indicate the minimal duties of a physician and specify the limits. But the future of the profession, if it can continue to be a profession and not turn completely into a business, the future of the profession depends on the doctor's integrity and adherence to the ethical premises of the profession. Fortunately, the doctors I know personally do that. But above all, the doctors must always appreciate the fact that we share a common humanity with the patient. Thank you.
Hi, my name is Abrams. I'm a physician and an attorney. There was something you said that I felt could have been misleading to some of the non-physicians in the audience that I wanted to clarify. When we were talking about the statistical differences that were found in amputation versus revascularization in different ethnic groups, and you mentioned the things that were controlled for, I didn't hear you say that they were controlled for diabetes or uncontrolled diabetes or untreated diabetes. And of course, as physicians, we both know that that is more prevalent in the African American or black population, and that could explain why they might have to go and undergo amputation more often because of microvascularization changes. The second thing that wasn't mentioned was the fact that people in poverty often do not seek help, whether it's for cultural reasons or not knowing or no funds, until their situation is so bad that they need to have their leg amputated, which of course is a societal problem, but it certainly doesn't impugn the ethics of the surgeons who offer the most appropriate treatment plan for a particular problem, having explained the risks and benefits. It could still come out that way racially. Second thing I wanted to mention is that I guess I wanted to get your take on the controversy with respect to the ethics of allowing people to sell their own extra organs if they prefer the money to the second kidney, for example. I had worked in the Military Enlistment Processing Center, the MEPS, and most of the enlistees who came in, or many, if not most, were poor. Some of them said, well, I want to enlist because I don't have any place to live and I don't have any money. We offer them money and we offer them scholarships. And it seems to me that the likelihood of dying from military service is greater than the likelihood of dying from having a kidney taken out. So I wanted to hear your own perspective on the kidney issue.
I must say that they did control for all of those items that you mentioned in the first place. The poverty, the background of...
The incidence of diabetes?
Yeah, no.
That's important.
Oh, yes, the incidence of diabetes. Yes, they took all the background, and I'll have to get you the article. Maybe I can get the reference for you.
I would appreciate it.
But it was very well controlled.
Yeah. I think that the reference would be helpful because we sometimes, when we generalize, we sometimes misremember exactly what was controlled for and how well it was controlled for. And it's possible that the physicians caring for these patients made racially prejudiced decisions with respect to who to offer amputation versus vascularization, but I'd want to see the actual research study before making that assumption.
It should be easy because this is within the last 2 months, this article. It may have been either New England Journal or JFA.
Do you remember the authors?
I can't recall it. It was a bunch of authors, several authors, but it's within the last 2 months. Because I just stuck that on the end of this talk. And you had another question about diabetes?
No, the other question had to do with your perspective on the controversy as to whether somebody should be legally permitted to sell an unnecessary organ like their second kidney or whatever.
Well, since the mortality rate from people who have only one kidney is a little bit higher than those who have both in terms of donation, that sways me in that direction.
But why should we allow donation? It seems to me that that's an logically inconsistent argument. But I mean, I don't want to take up all the airtime, but I would think that that is a logically inconsistent argument.
Yeah, well, no, I think I'm agreeing with you that we shouldn't allow it at all, theoretically.
Oh, I wasn't saying that. I was feeling that we should allow it either way.
Okay.
Once you explain the risks and the benefits. But because we don't prohibit people from going in to save somebody from a burning building, which is much more dangerous than selling your kidney.
Sure. Well, I can't. It's obviously a point of debate. I have no answer, good, bad, or indifferent.
Yes. And in our global warming presentation on Friday night, the subject of the human population as a driver of all the problems that are coming came up. Now, if we
Can't hear you, Justin.
well, can you hear me now?
Yes.
Okay. Should I start over?
Yes.
All right. In our global warming presentation on Friday night, the question of human population growth as the driver of all the problems with human industrial activity came up. And it's perfectly clear that the human race has been awfully stupid about this. We're already overpopulated, and there's been very little done. China has done a little bit, but it's even China has retreated from the more extreme policy they used to have on that subject. And if we're going to limit human population, which sooner or later there are going to have to be controls on that. And there's this argument that with wealth, birth rates decline, but that's not happening fast enough to keep up with the population growth. So if we're going to limit population, we need to think about what's the most intelligent way of doing it. And I think that Hitler did more harm in the long run by his embrace of eugenics than he did by all the murders of Jews and Poles and everything else. Because the Four Sigma Society, which is a group with a higher cutoff than 999, the 1 of 30,000 level. We did a study in 1980 of the number of children, among other things. It was a broad survey, but we questioned them on the number of children they had. The average age at that time was 35. And even if we assumed that at that time they'd only had half the children they'd eventually have, they were still reproducing at less than half the replacement rate. And we know, of course, what the reproductive rate is at the other end of the bell curve. So eugenics is necessary, but it has to be done right. And Hitler did it about as wrong as you could possibly do it.
Yes. Is that a question?
No comments from Fred. James.
Hello. I would note that my own home state eliminated the sterilization of epileptics 3 years after I was born. Fortunately, they missed me because I was not born to a medical doctor, but to a midwife. And in comment to the woman in front here who said she had noted a good number of people in the MEP stations would come to them because they had no other alternative or they were poverty-stricken. I was a Navy recruiter, and not a single person ever came through my office with that problem. No one ever stated that they had no other choice.
They wouldn't tell you because you were the recruiter. They wanted to get in. I mean,
well, my question though, I think I lost track of my question. So I'll pass it back.
Anyone else? Well, thank you very much, Fred. And let's have a little break, and then we'll come back with another wonderful medical presentation.